develop empathy and compassion for other people, there's going to be room for someone else in the relationship. And then this in turn is going to reduce the feeling of being an object. Now two people can connect. And now it's not about getting your needs met in starvation. It's about two human beings forming a relationship.
Alrighty, chat. Let's get started. Okay, so today... Oh, my camera's not working. Gotta fix that. Hold on. Chat. Technical difficulties. There we go. Then we're going to do that and that. Now we're good to go. Let's go, chat. Okay, welcome to another Healthy Gamer GG stream. My name is Alok Kanoja. Just a reminder that although I'm a psychiatrist, nothing we discuss on stream today is intended to be taken as medical advice. Everything is for educational or entertainment purposes only. If y'all have a medical concern or question, please go see a licensed professional. So today we're going to be talking with Dr. Mark Komrad. He's been practicing psychiatry for like 30 plus years and specializes in combining psychopharmacology with psychotherapy. And also does a lot of work in mood disorders like depression and bipolar disorder, but also borderline personality disorder, anxiety disorders, schizophrenia, and things like ADHD and attention deficit related disorders. So today we're lucky because Dr. Komrad is like an awesome psychiatrist. We're going to be meeting him in just a hot second. But there's the reason that we've invited him here today is because we get this question a lot, which is, I know someone in my life who needs mental health support. So like my boyfriend or girlfriend, like how do I convince them to see a therapist? I have a roommate, I have a best friend, I have a brother, I have a sister, I'm married to someone, my parents, my kids. How do I, like, I've been on a mental health journey. How do I convince someone that they like need some help? And Dr. Komrad is like literally the person who wrote the book on it. So he wrote the book, You Need Help, a step-by-step plan to convince a loved one to get counseling. He's also been awarded the National Alliance of Mental Illnesses National Award for being an exemplary physician. So he's an awesome, awesome resource. And, you know, like he's just been doing it for so long, and this is like an area of expertise of his. So if y'all have ever wondered, like, you know, how do I convince someone to go see a therapist or get mental health support, that's what we're going to be talking about. A couple of quick other announcements. So we've got a couple of membership streams coming up. We're going to be doing Emotions 201, which has been highly requested. We did sort of like a deep dive into emotions and sort of explaining how emotions work. So we've got a follow-up into that. And we're doing our deep dive into intuition this week. And huge apologies. We had a deep dive into autism stream scheduled on just as a regular stream on Twitch and YouTube. And that we had to reschedule because I got sick. So I know it was a very highly anticipated stream. My apologies. I'm still looking forward to it. And we'll probably do that this coming Monday. Okay. So let's hop in with Dr. Komrad. Give me just a second. Okay. So we're going to do, let's see if this works. Oh, nope. Okay, hold on a second. We've got a quick issue that we're going to fix. Done. Okay. Hello, Mark.
Yes, I'm here. Can you hear me?
Yes, I can. And then I'm going to, it looks like we have a slight problem once again. And I'm not quite sure how to change it. So the label for your name is wrong. So give me just 1 second, because I think we got to fix that. Oh my God. Okay, so it looks like it's not editable anymore. Give me a second.
Certainly the label that's on my screen for myself looks right.
Yeah, it looks right. It's just a problem on stream. Let me just make sure that we get this right so that we appropriately get this going. Hold on. Give me just one. Sorry about this, Mark. That's okay. Maybe we can do. Okay. All right. Well, maybe we can get started, and we're going to kind of. Okay. That's weird. Maybe we can get started, and then we'll see if we can sort of figure this out in a second. Okay, we'll sort this out. So I have someone working on it, and my apologies for getting your
Listen,
name.
if a tech savvy guy like you can't figure it out, makes me feel better that with my own computer hardships.
Okay. So thank you so much for coming today, Dr. Komrad. So do you go by Dr. Komrad, Mark? What do you prefer? I know
Whatever. Because you and I have known each other in another context, I'm fine with Mark.
Okay. So can you just tell us, Mark, a little bit about kind of your background and the work that you've done?
Mm-hmm. Right. So in terms of my background, so I am a psychiatrist, as you pointed out. I trained in psychiatry at Johns Hopkins, where I did my residency, went to med school at Duke. And after Johns Hopkins, I've had a career with a variety of parts to it. So one part is treating patients, which I did as an inpatient psychiatrist, helping to run the treatment-resistant psychotic disorders unit at Shepherd Pratt Hospital in Baltimore, Maryland, which actually is one of the largest nonprofit psychiatric hospitals and healthcare systems in this area. So I did that for about 25 years. In addition, I have another dimension of my career. I have another hat that I wear, which is as a medical ethicist. And I ran the ethics committee and the ethics consultation service at that healthcare system also for about a quarter century, and also traveled all about the country and around the world, consulting and teaching about medical ethics in general, but specifically a lot of the ethical issues that come up in the domain of mental health and psychiatry, behavioral health. And then also, I was very involved and very concerned about the way in which psychiatrists are portrayed in the media. In addition to the way people with mental illness are portrayed, but my particular point of departure was how we psychiatrists are portrayed with some very common distortions and stereotypes and archetypes that come out, particularly in movies.
Like what?
Like, for example, something that seems to be very much in the press these days because one of our presidential candidates keeps bringing him up, Hannibal Lecter in Silence of the Lambs. And in fact, it was, I mean, it's interesting because it's relevant to how we got to the topic today. So I saw Silence of the Lambs when it first came out, and actually saw it a little bit after it had won the Academy Award for Best Picture. And that portrayal of this scary, flesh-eating psychiatrist who lives in the dungeon with all the furies in actually what is supposed to be a forensic hospital like the one we have here in Baltimore. It's set in Baltimore. Having seen that, I thought, you know, a lot of people are going to see this, and most people have never been to a psychiatrist, even met a psychiatrist socially. And so most of what we learn about who we are and what we do really comes from movies. It's a little bit like, you know, how do I know what the life of a cowboy is like, or what life in space is like, or what it's like to be in prison? Well, I don't have any personal experiences with that, but I know that from movies. So I began to uh, think a lot about how we psychiatrists are depicted in movies and some of the common distortions, which led me into another part of my career, which was consulting to Hollywood to try to help them get more
Cool.
accurate and ethical portrayals of who we are and what we do. But the interesting thing is that uh, I came home, I stayed up all night, I guess in a hypomanic frenzy. I was so disturbed by this issue in the film. It was a great film, but I wrote a manifesto that
Hmm.
night, a 15-page manifesto. And in that manifesto, I spoke about how we're portrayed in the media and what a problem that is and how that contributes to mental health stigma, how we get, as Irving Goffman, the famous psychologist, once called it, the courtesy stigma that psychiatrists get from their patients, and how that may actually be part of what makes it sometimes people reluctant to come to get this kind of help. And I said, we really need to do something about this. We need to take some ownership of this problem and its solutions and start to interface more vigorously with media. Now, mind you, this was the early 90s.
Okay.
Okay. So uh, we need to be involved more in media. In fact, we should become part of the media.
Hmm.
So I distributed this to a variety of people, including the public relations department of the hospital that I was working in, Shepherd Pratt Hospital. So about a month later, I get a call from the public relations department, and they said, there's a national uh, medical radio talk show that interviews doctors.
Hmm.
And they called us up and they asked if they could interview a psychiatrist. And I read your thing and I thought you'd be the perfect guy to do this. So I said, all right, well, that would be great. It turns out that this national radio show, talk show, a 2 hour long talk show broadcast out of Baltimore,
Hmm.
where I am. So I went down to the studio and the name of the show was Doctors on Call.
Hmm.
So the host interviewed me for 2 hours and we took calls. I mean, it was somewhat similar to this format, except that we took live calls, is the caller there? And she'd bring in the calls and people would ask me questions. And we spent 2 hours covering many, many diverse areas in the domain of mental health and treatment and meds and the mental health system and everything. So I had a great time. At the end of this 2 hours, the producer said, that was terrific. We'd like to have you back. And I said, oh, sure, I'd be glad to come back. So he said, how about next week?
Okay.
And I said, well, that's a little soon, but I could do it. He said, good, come back next week and come about a half an hour before you came today. So the next week I come back and we sit down in the conference room and I noticed around the table with the producers and I noticed the host was not there. And I said, it was a woman. I said, where is she? I said, well, as a matter of fact, we decided to let her go. And we'd like to know if you would be willing to be the host of a show all about psychiatry.
Interesting.
Yeah. So I said, look, I don't know how to run the board. I said, it's easy. We can teach you in 15 minutes. And the engineer behind the window, will bring in the callers and so forth. I said, okay, I mean, that's interesting. Put me on the spot. I mean, we were about to do a show. So I said, look, I'll try it today. We'll see how it goes. So we did, and it went very well. And they said, so do you want to keep doing this? And I said, yes. I said, all right, well, what would you like the show to be called? And I said, well, what was the name of it before? They said, Doctors on Call. I said, I don't know, Komrad on Call. So that was the beginning of Komrad on Call.
Comrade with a K.
With a K. Right, Comrade on Call with a K, but no, my wife hates that sort of thing. So that started a radio show that went for several years 43 million listeners, coast to coast, even out in Hawaii. It was a 2-hour show. And for 1 hour, I would interview a colleague about some specific topic in psychiatry, anxiety or depression or PTSD or emergency psychiatry and so forth. And we'd take calls. But the second hour was always open phones. I called it anything you've ever wanted to ask a psychiatrist but never had the time. So, and the phones would really light up during that particular hour. And I'd feel, just like I did in my first appearance, I'd feel calls from anything people wanted to ask. But the most common question over the course of those few years that I did this, and I went on to other media stuff on NPR and on some TV things, but when it was my show, most common question that got asked was the very question that you started this segment with, which is, I have a loved one, a friend, a spouse, a kid, an uncle, a coworker who I'm worried about. And that person clearly needs more help than I know how to give them. How do I convince them to see somebody like you, doctor, a professional, a mental health professional? Because many people were acknowledging that that's often a very hard thing to convince people to do.
Absolutely.
Particularly in the setting of the more serious mental disorders in particular, because of some of the features of those disorders. Often people don't have insight into the fact that they're ill and so forth. So I would brainstorm with people, well, what have you tried? And have you thought about this? I'd educate them about, things that they needed to be educated about, and talked about the resources and so forth. So I did that over the course of the year several hundred times.
Wow.
So that, because it was such a common question, so that became a specialty of mine. And because people knew me from the radio and so forth, I began to field calls from people who wanted to come to consult me on this matter in my office. Or
what do you mean by that? Consult, like
so they wanted to say, I have my 23-year-old son, right, or my mother, I'd like to come and sit with you and talk about her case or his case. And
so these would be the loved ones that want to come to your office and want like a more detailed, like, here's what's going on. Okay.
Right. And so, and as technology evolved, it started to become online as well, and did phone. And I actually was fielding these consultations from internationally as well as, around the country, and particularly in this area. If they lived close by, they could come to the office. And after about 20 years of doing that, I put everything that I learned into this book. You Need Help, a step-by-step plan to convince a loved one to get counseling. And it's interesting because the title, when you publish a book, you get to say mostly what's in the text, but you don't have any say-so about the title. The publisher decides the title, unless you're self-published, which this was not. It's published by Hazelden Press, which is a large mental health press that's associated with the Hazelden Treatment Center, which has now become the Betty Ford Treatment Center. So they convened focus groups to try to figure out what would be a good name. And they came up with this title, which I really like, You Need Help, because it really has several levels of meaning, right? We could be talking to the person who is having the primary mental health problem, right? Or we could be talking to the loved one who needs help, trying to convince that person to get help. And also, as has often been the case when I've worked with folks on the helping end, they sometimes need their own mental health help.
Sure.
Whether
as
it's
caregivers.
Because they're either as caregivers to help them cope, and the burden of a family member in particular having mental illness can be quite severe. So for support, or sometimes some of these helpers were part of the problem. And
can you tell us a little bit about that?
That's a whole very interesting dimension here. one of the things, and I talk to a lot of groups around the country, lay audiences, either you often give a talk about the book and then followed by open phones. You can ask me anything. And one of the things we talk about is this issue of enabling. And, I think that the important point is that enabling is really a subset of love. I think it begins with the good intentions. It begins with trying to do your best. It begins with love, with caring, with compassion. However, as the effort goes on, it becomes increasingly problematic how you are deploying your caring. And you can very easily go down the rabbit hole of inadvertently enabling the problem.
So can you go into a little bit more detail there about, like how does that happen? What have you seen, right? So it starts with good intentions where we want to help or support someone. Can you actually just start with explaining what enabling is? I mean, I think everyone kind of knows, but let's just define our terms.
Right. Well, interestingly, enabling had its origins in, at least in a clinical sense, in the world of substance abuse. It was sort of first recognized as some of the vulnerabilities of people who were in relationships with the substance user. And it actually led to an entire sub-world in the recovery world of the Anon programs, Al-Anon and Narc-Anon and so forth, were sort of the original areas in which this kind of dynamic was first identified. But we've come to utilize it in a wider sense in all sorts of clinical settings. Maybe it even has value in political settings too. But we use it in clinical settings to designate the fact that the behaviors of a person who is proximate and engaged in a relationship with a person who is having a problem is engaging in behaviors that actually helps to either sustain the problem or propagate the problem. And because it always is, it typically comes up in the context of an interpersonal dynamic between a person with the primary problem and then the person who's proximate to that primary problem. It happens in a caring context. I'd like to say, a loving, caring context. So, the helper or the proximate person certainly intends no harm. Is trying to do the right thing, is trying to help mitigate the problem and improve the situation and reduce the suffering and so forth. But sometimes inadvertently, I want to keep coming back to that term, ends up doing things that are in fact counterproductive, maybe even certainly non-productive and maybe even counterproductive.
And I mean, I know that, you're bound by doctor-patient confidentiality, but I'm wondering if you can share with us a generalized example of what does this look like practically? What have you kind of seen?
Right. So a typical scenario in my consultation is the most common scenario that I consult on is with parents of a young adult.
Okay.
Who has more serious psychiatric symptoms. Okay. So serious that the parents are being overwhelmed and need a consultation. What can we do to help our kid? So in that kind of a scenario, we often see things like the young adult is refusing to get treatment, is continuing to malfunction in sometimes very serious ways, right? And yet, the parents enable them to continue to avoid treatment, even though they may even be asking them to get treatment, by doing things like giving them privileges, uh, privileges without necessarily any corresponding responsibility. Giving them a car, giving them a cell phone, putting them up in their own apartment and paying for, paying their rent for their apartment while they basically have a life in which they're living in bed all day, and possibly hallucinating or, you know, making a terrible mess of their environment. So on the one hand, asking them to get help, but on the other hand, enabling them to feel comfortable with minimal consequences.
Mm.
Or, they're having trouble doing their homework because of the underlying condition. So the parents will not only help them with their homework, but finish their homework for them,
Mm.
right? So that, they don't have any consequences back in the classroom, right?
Yeah. So I'm sorry. Keep going.
Yeah, no, go ahead.
So I think like that makes a lot of sense, and sort of just I'm reading between the lines here when you sort of say severe mental illness, like more severe mental illness, and you're talking about Shepard Pratt, and you were an inpatient psychiatrist for 25 years. So, my mind is going back to, let's say, like bipolar disorder, severe depression, maybe first onset schizophrenia or something like that. Like these are like serious, mental illness or mental health concerns. The stories that I hear more of, and like I hear these, like, people will personally reach out to me, like people in my personal life, not even professionally. I think the scenarios have changed a little bit, and I'd love to get your kind of take on it, right? So the classic one, of which I was guilty about 20 years ago, right? So I'm like, you have, it's sad, but very commonly what I hear now is we're new parents. So you have a husband and a wife. Husband is a gamer, usually a dude. And then, the spouse is like not quite sure like what to do, because now that there's a new responsibility here, they don't know how to communicate to their spouse or loved one that like they need help and they can't play so much. Sometimes there is something like a new child in the picture. Sometimes there isn't something like a new child and we're just playing way too many video games. It can also be something like a sibling. Like, so I've had, I one time had a patient who had a sibling move in with them after college and was just gaming all the time. So it almost sounds to me like there's and maybe this is a mistake on my part, like a clearer answer. Like if someone is like hallucinating in bed for, 3 weeks in a row, that to me seems like an easier, it's easy, or maybe not, but like that's like, that's severe. I think part of the challenge is that a lot of people think that someone in their life needs help, but the problems aren't quite so overtly severe.
Right.
And
so I agree with that. And in fact, only the minority of people who need mental health treatment, could benefit from mental health treatment, have severe illnesses. That's quite right. And, in my practice of treating patients, as opposed to this consultative role that I do, yes, I see those very same levels of problems, are much more common. They're not the sort of thing that people, cross the country to come consult Dr. Komrad about. No, I absolutely agree. And, the fact is that one of the things that my book is kind of organized into different sections. So the first section is, what do we mean by mental health problem? The second, and which is the largest section, as a matter of fact, is why do we even need a book like this? Why don't people show up for treatment? You don't tend to need a book, how to convince somebody to see the orthopedic surgeon, right? Or the urologist. What are the many factors? And we can talk about that if you're interested, some of the ways in which, many sociological, cultural, financial, manpower issues come into play, as well as the nature of some of the conditions themselves. Then the third part is, how do you approach somebody in the beginning, right? Some of the do's and don'ts, and how to start with facilitative conversations. And those facilitative conversations about how you approach somebody that you care about, that you're concerned about, that you are in a relationship where you, as the helper, unlike me, your point of departure is caring and is love, right? I mean, I care about my patients. To some extent, I may suppose you even love my patients, but it's a different kind of relationship. So uh, how do you use that posture? And those are the more common problems, how to talk to somebody in a way.
Yes.
In terms of the enabling situations, those tend to, because enabling leads to worsening of a situation, it tends to be associated more with more severe kinds of impairments. Uh, and that's where we get into the third part of my book, which is what I call therapeutic coercion,
Okay.
uh, with, which I know I make no bones about it, right? That sometimes you need to close doors so that people can't walk through those doors and open other doors that you would much rather see them walk through, by considering what may be the enabling factors and what may be uh, the, uh, the contract for what are the benefits of particularly family membership,
Hmm.
uh, and how those benefits have to be coupled with responsibilities, such as the responsibility to get your health properly evaluated and treated, right? And then the final part of my book is uh, is for situations where it's really all of these persuasions. And by the way, I have a whole thing about the use of allies who are good allies, which relatives, primary care physicians, coaches, rabbis, priests, because they're sometimes you really need other allies. And we talk about interventions there. But the ultimate level is, especially in the much more serious situations, if all else fails and under certain circumstances, is involuntary treatment. Uh, that is going beyond the authorities that are available in a family or friendship system, uh, and utilizing outside authorities that may be necessary, such as the police, such as the emergency room, such as the courts, such as the jails and prisons, which can actually be part of a plan under certain circumstances as well, homeless shelters and the like. So that's at the very tail end of a hierarchy of severity and certain kinds of interventions. So I would say addressing enabling um, is something that is kind of in that intermediate zone, which is where I tend to see enabling beginning to occur.
Yeah, so I'd love to go like through each of those almost like kind of one at a time, and maybe what we could kind of do is go through almost like a case kind of approach, right? So let's say that does that work for you?
Sure.
And then if we don't get into some of the details, I've got kind of like a list of questions that I've been taking notes about. So, let's say that I have a loved one who's spending too much time on a screen. How would you facilitate this conversation? Like, so you mentioned the posture that you take with approach. And
Yeah.
oftentimes, what happens is telling someone you need help can kind of backfire. And so, how do you approach that? Like, what's the most effective way?
Right. Well, first, what we have to review is, sort of some basic do's and don'ts of that first approach, right? So, that I think are important, fundamentals. So, for example, don'ts. If you're going to address this problem, you don't address it in the middle of the night. You don't address it when you are intoxicated or the person that you're talking to is intoxicated. You don't address it in sensitive and potentially embarrassing times, like at family gatherings, at special events, weddings and things like that. Those are not good times to be digging in. It is not good to address your concerns in the middle of an argument or frankly, right after an argument when your amygdala is still continuing to fire even after the argument is over, and people are still brittle and reactive. Or you don't address this through as much as possible through remote means like emails and texts and Facebook, especially, or telephone. That these are conversations that have to be in person, right?
What
And
does sorry, is it okay if I jump in with questions?
always, yes.
So I think we're in an increasingly digital world. And so what's the value of doing it in person?
Yeah, because I think that one of the things in the digital world is it's very difficult to engage in complicated, nuanced conversations in the clips and bytes of a text, of an email, and there's not a lot of opportunity for dynamic exchange. Sometimes, that may be the only way you can access a person. I understand that, in which case, that's what you got to do. But particularly if you're living in the same house with somebody, or you have, a lot of proximity to them, I really think that the optimum choice is face-to-face conversation, body language, non-verbal behaviors. It's in the era of COVID, of course, we mental health professionals went to virtual treatment, and for some people, particularly older people, couldn't handle the technology of even FaceTime, or they didn't have an iPhone, or know how to use WhatsApp, or let alone doing Zoom or other platforms. So I had to treat a number of people by phone. And I really became, especially there, and to some extent even on Zoom, became especially aware of how much is missed when you do not have visual contact and proximity, and and the kind of mirroring that goes on in a live, in-person, visually accessible conversation.
Yeah.
So that's why I think that for sensitive conversations, for difficult conversations, if possible, in person is preferable.
I sort of have, it was interesting because when I was doing my psychiatry, when I was in residency, we spent a fair amount of time on even positioning of the office. And how you sit. And one of the interesting things about Zoom is we're facing each other, which is like one of the main things I was taught as a psychiatrist is like, don't sit across from the patient, right? We want to be kind of like at an angle to each other. And it's crazy. I'm not a very good couples counselor by any means, but sometimes I have to throw my hat into the ring because a patient needs help. And so I went to one of my colleagues and was asking them, like, hey, I'm doing this new thing. Like what, how can I not screw it up and do it a disservice to my patient? And so, they gave me a couple of really simple tips, like have your patient and their partner sit next to each other, which I found that has been like transformative for my own relationship. Like it's so different when you're, sitting next to each other, especially if there's like a romantic relationship or there's like a parent-child relationship. There's some amount of like physical contact. You can even hold hands or something like that.
Right.
And that softens the words.
Yes.
So much.
As a matter of fact, under those circumstances, so for example, if I'm sitting with a couple and one person says something particularly nice about the other one to me in the third person, I'll say, why don't you turn to them, take their hand, and say it right to them now? Yeah,
it feels so awkward when you first do it,
Right.
So that's so interesting. So I think you've really found that. And best practices, if you can have the conversation in person, do it in person.
Right.
So I think you were going through your don'ts.
Right. So now we're into the do's. So here's a do that I have found useful often, which is prepare the way. So what does that mean? So rather than just spontaneously, kind of jumping into a conversation, to actually alert someone to say, we're going to have an important conversation about something that's very meaningful, right? So there's something I'd like to talk to you about. And typically you can reassure them, nothing bad, nothing terrible. I'm not going to, it's not that I have to tell you I have cancer, right? Um, but I'd like to do that, tomorrow night, when you get home from work, for us to set aside some time. There's something really important that we really need to have a conversation about. So people often end up, trying to think about what it could be. Sometimes they realize what it could be, but it creates an expectation set, a salience set that really, and people are prepared to actually sit down rather than while you're on your phone, somebody comes off, that we're actually going to have a face-to-face sit down, what we in our business call a session.
Yeah. So I'm so curious about that because I get where you're coming from. So the importance of, frame setting and signaling to the people. If you don't do that, people can oftentimes feel ambushed. If they feel ambushed, the amygdala reacts. They're not really listening to your words. They feel attacked. So I can totally get the advantages of it. And at the same time, I'm also imagining, oh, hey, Mark, we need to talk. Right. And that even sort of saying that and not providing a reason, because I noticed you said you don't tell them what the conversation is about. Like, does that cause people to kind of put up their guard and be less receptive? Do you recommend telling?
Well, sometimes it does. Look, not every one of these techniques works with everybody.
Yeah.
So just like, the medications we prescribe don't work with everybody that we prescribe them to, right? So we have a toolbox of different tools and different approaches. But that's why I think, you need to give some reassurance. It's, nothing terrible, nothing bad. So, I think being able to set someone at ease is very important. By the way, even if it is terrible and bad, right? You may want to give a white lie, and because you're trying to take the most positive approach of it.
I see. So you would, and I get that, like, based on your hundreds of consultations, this is kind of what's floating to the surface. May not work for everyone, but on average, this tends to work pretty well. And do you find that sort of telling them, hey, we need to talk, provide some reassurance, but don't tell them what the topic is about? Is that on average better?
Yeah, well, on average, yeah. I would say it works more often than not.
Okay.
So, again, when I talk to people, I use the word brainstorming. Let's brainstorm some ideas. Well, you tried this. Well, okay, that didn't work. Okay, so let's try this approach. But this is a common one.
Okay.
That I think is valuable. Then I think that it's important to find a place that's emotionally neutral. So in other words, you don't talk to your sister in the childhood bedroom of your parents' house where the two of you grew up in a family of conflict, right? So that would be a very a non-neutral place, a very emotionally evocative place, right? So you find a place that is emotionally neutral. I tend to think that I recommend, especially for spouses, to actually not meet in the bedroom, right? Because the bedroom is loaded with too many associations and too many vulnerabilities. So the bedroom is not the place, maybe the kitchen table, right? And then also in certain circumstances, however, if you feel unsafe, that this conversation might not be the safest thing to have, I actually have advised people sometimes to meet in a semi-public place, like on a park bench, right? Or at a cafe table where you have at least sufficient privacy, so that if there's going to be any kind of adverse acting out, on the part of the person talking to, they're going to be much less likely to lose it if you're in a public place. So those are examples of some of the do's. Uh, then I think certainly in the work that I do, thinking about my point of departure, which is my work in this book, that the whole purpose of this book and the whole purpose of my consultations is to get the person in the door, right? It's actually not, because this book is not about how to convince people to stay in treatment. That's a whole other book, right? But once you get them in the door of a mental health professional, then you have a new ally, right? You have a trained person who hopefully knows how to create an alliance, who knows how to create a therapeutic, attachment, who, for me, especially not when I'm doing a one-time consultation, but when I'm seeing a patient for the first time that I'm intending, hopefully we'll be working together in treatment, my primary goal that first visit is to try to convince the person to have a second visit, right? Because that actually, if the person agrees to a follow-up appointment, we're on our way.
Yeah, so I think it's already, I'm appreciating just a lot of things about what you're saying and kind of what the book offers. The first is that the number of things that you offer guidance on that I would say the majority of people, myself included, don't think about. Right? So when I'm working with people who are like struggling with, let's say, technology addiction and a loved one, the last thing on their mind is, where in the house am I going to have this conversation? It's always like, what do I say? And just even thinking about, medical literature, one of the things that we've learned is that it's not just the treatment itself. It's not the pill that creates the effect. There's a whole host of other factors, the setup, the environment, teeing up for something that can really influence what the outcome is. And like a couple of these really simple things, like the most common time that, I would say the most common time that people have these discussions is during an argument, right? That's when it comes up. And so you're kind of shooting yourself in the foot, and just the awareness of how many factors, like you can kind of stack the deck in your favor is kind of what I'm getting.
Right. And look, you control what you can control. You frame what you can frame. Right. And that there is a certain skillfulness to this. I mean, I'm trying to teach people skills, actually the skills of persuasion, and at the other end of the spectrum, if necessary, of coercion, right? Which, I do it. I'm sure we'll eventually get to. But at this level of entree to the problem, we're trying to get attention, right? And to be taken seriously. Right. So the where, the when, and the how all go into that initiation.
And what about the what? So when it comes
right. So let's talk about the what a little bit. Okay. So first of all, I think it's still establishing, because this is a what, the frame, which is two things. One is, I want you to know our relationship is really important. So most of all, the thing that's most important to me is our relationship. And that what we're talking about here, I do not want it to in any way endanger our relationship, because our relationship, I care about you, I love you. And that's really, a very important thing to say up front. However, then to be able to take the next step, which is, what other feelings are you having besides caring and love, right? Your worry, your concern, right? I'm coming to you because I have a worry, I have concern, or I'm feeling bad about something. I'm feeling frustrated about something, right?
What
So
about
even before,
anger, resentment?
yeah, anger, I mean the whole
Okay,
palette,
interesting.
right? Yeah. So, but I think you have to be careful with certain things. I'm angry. There are certain triggers that trigger defensiveness. I'm really angry at you because. So, some initial feelings that are feelings that allow other people to empathize with you, right? So worry, concern, fear, scared. Okay. These are the things that evoke empathy more than defensiveness.
Interesting. Yeah, that's a cool strategy, right? So to
Yeah.
really think about what part of your experience you want to share, and some things will promote empathy, and some things will promote defensiveness.
Right. Right. All right. So then, having set the attention and the emotional tone, okay, then the focus, the next focus needs to be the specific behaviors. Okay. So behaviors like you haven't gone to work, 2 weeks out of this month, or you came home, you really embarrassed yourself when you were out drinking with our friends the other night, or I notice you can stand at the sink and spend 45 minutes washing your hands, right? Or you're spending so much time on the video games that I'm missing you.
Hmm.
I'm missing our time together. Or, our child, is missing opportunities with you. So you're pointing out behaviors. You are not making a diagnosis. You have OCD. You're an alcoholic. You have gaming addiction, right? Absolutely. The whole journey here is to actually maybe end up in the company of somebody who will come to such a conclusion, right?
I see. So
Well,
yeah, so you're kind of pointing out symptoms or behaviors as
right,
opposed to conclusions or diagnoses.
exactly. And that's very important because, first of all, I mean, frankly, you as the, unless, and frankly, even if you're a psychiatrist, you shouldn't be pointing out the diagnosis because, if I try to do that with my wife, she does not take that very well. My wife, who often sometimes says, "Do I have to pay you to get you to listen to me? Uh, do I have to make an appointment?" So it's endemic to our profession. So you don't want to, because you don't have the expertise. And by the way, most people throw around diagnostic terms nilly-willy in ways that no trained clinician would necessarily want to endorse the application of that name to this problem. I mean, common examples: OCD, bipolar, right? ADD, PTSD. A lot of people self-diagnose, say, "Oh, I'm so OCD, I'm so ADD," right? Boy, I'm so upset that I really have PTSD. I'm so upset with my boss, right? So, these are well defined constructs, and as in any field of medicine, diagnosis is the first step to the two most important uh, sequelae of that, which are therapeutics. What do you do about it? And prognosis, which is what's going to happen if you don't treat it, and what might happen if you do treat it. So, I mean, that's the sequence of how clinicians think. Uh, and we've worked very, very hard in trying to articulate our diagnostic constructs, and they still have a lot of problems, as I'm sure you're aware. But that's an area of expertise. So you're not in a position to say you have an alcohol addiction, right? You have a video game addiction. I mean, addiction is a specific concept, is a specific construct. So, um, so avoid diagnoses. And then also, very important to be careful about triggering and stigmatizing words like crazy, insane. You're acting crazy, right? Um, so, so focusing on the behaviors, not offering the diagnosis, and utilizing language that's not triggering. And I think it's very important in going into, see, this requires some prep, right? Some forethought. So these kinds of conversations, you don't want to shoot from the hip, right? So having these kinds of notions as part of your preparation going in. So another aspect of your own preparation is you need to be prepared for the person to be resistant, right? You need to be prepared for them to even be ruffled, to actually maybe even be angry with you. So you have to be prepared to not get your own defenses going
How do you do
in the
that?
face of that, right? So what you do is, first of all, you prepare in advance to say, okay, I'm going to recognize, uh, you know, that if this person gets angry, I'm going to recognize, okay, now I'm there. I'm in that vulnerable state. So you know what to look for anger. Okay. And then you keep circulating back to the basics. I love you.
Hmm.
And here are the behaviors that I'm worried about.
And
Or,
so
yeah,
that's really helpful. So it's just to think through kind of mentally, like, okay, like when I, say something, and if this activates this person's defenses, sometimes they're going to hit back, right? Hey, I'm concerned that you made an ass of yourself when when we were out with our friends. And then, people can hit back with, well, you made an ass of yourself when ...
right.
And so I'm kind of curious also about, like, not only that, and so just mentally don't get taken off
Don't
track.
get,
And
don't get hooked.
yeah,
Right.
right. So dodge the bait. And then the other thing that I'm kind of curious about is, like, I'm sure that part of that resistance, so this is something that, we hear a lot, is that people will offer some kind of reason, explanation, or dare I say, excuse. So, oh, I'm gaming so much because, well, I'm under a lot of stress right now. Like, this is affecting me. Something that I think is really interesting nowadays is I'm starting to see a lot of mental health actually as an excuse. And so there's this weird thing where it's like, oh yeah, this, like, the reason I drink is because I have PTSD, or, like, something like that. People say, oh, I'm stressed out about work. And so when the person that you're talking to attributes some other reason, how do you kind of roll with that?
Right. So the bottom line is whatever the cause, okay, the problem is continuing. And the problem is having consequences. Consequences to our relationship, consequences to the kids, consequences to your job, and consequences to your school, right? I mean, when we think about, what rises to the level of a psychiatric disorder, this book here, right? The DSM, right? I mean, it's often been criticized as, what's not in here. To what extent does this somehow cover all of human behavior? So is everything a potential, well, the DSM means the Diagnostic and Statistical Manual of Mental Disorders. So is everything a mental disorder? Well, in fact, for almost everything that's in this book, they all include a criterion, which is affects and interferes with your functioning in work, school, family, in the context in which you have to function, right? So not all human distress is necessarily a mental disorder, right? So, I mean, people get distressed, right? So when does it rise to the level of a clinically significant disorder, which, again, what we're here to talk about is, because there are other levels of ways that you can provide help to people, right? You can be a friend, right? You can be a good hairdresser who listens
Mm-hmm.
to your client, right?
Bartender.
Uh, Bartender. You can be a coach, right? both a conventional coach, sports coach, as well as a mental health coach, as Healthy Gamer specializes in, right? So there are many preclinical levels of help. You can be in a support group, right? You can, talk to your clergy person, right? So I would consider all of those preclinical. And the fact is that the majority of human distress can basically be addressed preclinically, in all of these levels. And, I'm very happy as one of the things I'm learning a lot about, and frankly, you are one of my teachers, which is how we know each other, is coaching. And I'm, learning about that. I would call it, just subclinical level of help that people are getting. I think it's wonderful. It's terrific, and very actually. If I'm going to write a second edition of this book, I'm going to have a chapter about all these preclinical things, because they can be bridges for people who might be on their way, who need actually something that's over the clinical threshold. They may find their way over this bridge that comes with things like coaching.
So I'm kind of hearing you say, when it comes to this conversation, like, focus on, if people are kind of dodging the responsibility, that we kind of really focus on the consequences, right? So
Right.
like whatever the cause of the problem is, fair enough.
Right.
These negative things are real. And then
Yes.
how do you, yeah, go ahead.
Okay, so again, back to the book's title, You Need Help, right? So where we're at with this, with these behaviors, with these symptoms, is that whatever we're all doing and however we all are understanding what's causing this, it's not getting any better, right? There's still, you seem to be suffering, or I seem to be suffering, or our family seems to be suffering, our employees seem to be suffering, right? So whatever you want to call this as the cause, the DIY approach doesn't seem to be working out very well, right? So we need more help. You need more help. And I like the we, especially in a relationship, especially in an intimate relationship, as opposed to your friend, right? We need more help here than I think any of us really know how to give, right? So let's see if we can talk to somebody who understands these kinds of problems, these kinds of behaviors. And let's figure out, if you're having trouble with stress and coping, let's figure out, some tools that you can use to better cope with stress. If you're having, a condition that's due to some kind of underlying medical problem, let's figure out what that medical problem is and what the 21st century has to offer in treating that medical problem. So, but let's go beyond the do-it-yourself approach, and let's get you evaluated by somebody who might be able to give you some tools to empower you, fortify you, and give you, a toolbox.
And how do people usually respond to that?
Well, again, so there's an algorithm, right? So if you respond well to that, off you go to an evaluation. We can talk about how you find people and so forth. But so if that branch of the algorithm, if they're responding well to it, right, then you go off in that direction. By the way, one of the important things that I emphasize in the midst of this, some additional persuasive tips before we go into the other arm of the algorithm, are a couple of things. One is, this has worked several times, which is to ask for going for such an evaluation as a gift. You know, our anniversary is coming up,
Oh,
and
wow.
I'd like you to give me something that you cannot get in the jewelry store, something that's more precious than rubies, right? My birthday's coming up, and can I tell you what I'd really like for my birthday or for Christmas this year? That would mean more to me than anything you can find in a department store,
Wow.
or any donation you can make to charity in my name.
I feel a
Right?
lot of emotional leverage there.
Yeah, well, absolutely. We're talking persuasion here, right? Persuasion and healing. So, you know, these are all techniques of persuasion in challenging situations.
Yeah. So, I mean, I also really like, I'm appreciating, there's some things that I kind of expected to hear. And there's some things that I think are just incredibly valuable because I think like this is about persuasion and coercion, and you're calling it what it is, and sometimes that's what it takes. And I
Right.
think that the real challenge is that you know not many people write a book that involves coercion. Not many people, because we view it
And we'll call it that.
exactly right. So that's what
Right.
I
It's
think
usually
is
called
kind of
tough love.
it's kind of ballsy, and I think it also speaks to like a reality that we live in, which is that sometimes human beings like need consequences. Sometimes they like need to be pushed, and there's this like Instagram first positivity. Everything is like rainbows and fuzzy and friendly and empowerment and this and that, and like sometimes like you kind of gotta be very like harsh with people. Tough love.
Yeah.
It,
You, right. And you know, we live particularly in a culture, in this culture, in a world in which there is a lot of focus on privileges, but not a lot of focus on responsibility, or not as much focus on responsibilities, privileges and entitlements, right? But the hydraulic between privileges and responsibilities, and the triangle, privileges, responsibilities, and consequences, I think is, a vital triangle of, wellness, indeed, survival. And I think working with that three-legged stool, privilege, responsibilities, and consequences. By the way, consequences can also be rewards. Right. We tend to use the word consequences with its negative connotations, but there could be positive consequences, which is, of course, what we're all hoping for here. So this has worked several times. This gift, I'd like this as a gift. Another thing that can be helpful, particularly because I have sometimes this conversation comes up not by people that I don't know who come to me for this kind of consultation, but with my own patient that I'm already treating, who is worried about somebody in their lives, right? And it says, okay, well, how do I help them get a bite of the same apple, that I'm having here? So sometimes it can be very effective to share, if you're in treatment, to share your experience with treatment. Hopefully it's valuable and positive, which is why you're still in treatment, right? To share your own experience. Why did this work for me? What was my reluctance? How difficult was it for me to get started? What kind of resistance did I put up when it first happened? What kind of DIY approaches did I exhaust? What other people was I affecting, probably adversely, probably more than I should have, before I finally decided I need some additional help, rather than the do it myself approach, and just chill and listen to nice music and talk to my hairdresser,
yeah.
right?
Okay.
So that's another thing. And then I think the other thing is, what if they say no? What if they resist? I think one of the most important principles here in this journey, in this program, is you keep trying. You don't say, "Oh, I had one conversation with it. They didn't care. It didn't listen. It didn't result in anything. So been there, done that." Right. This is a project and may take repetition and may take, look, we need to talk about this again. That there is some attrition that may be necessary in addressing the problem. Now, that may not work. It may backfire, right? And we know that. So we have the algorithm. It can go yes or it can go no, right? But I think that it's very important to not say tried it once, didn't work. By the way, for any of these things that we're talking about, tried it once and it didn't work. I have when I give this when I talk about my book, when I give workshops about my book, I have a slide. And the slide says what people think success looks like. And it's a straight arrow. And what success really looks like is an incredible knotted path that eventually has an arrowhead at the end. And I think that's a very strong visual for this particular point that I'm making.
So can we talk? So we do have a couple of, like, I just want to be mindful of time. I know we've got about 45 minutes left.
Sure.
So I had two thoughts. One is if we could kind of talk a little bit about, if they don't say yes. And then we do have a set of like posts that I was hoping I could get your thoughts on. I'm not sure if you want to address, maybe we can talk a little bit about coercion. Scary term, but sometimes that's what it is.
Right.
And so maybe we can talk about that, and then can we field some posts, which are...
So let's talk about coercion, and we have all sorts of euphemisms for it, right? Therapeutic coercion, tough love, right? And I think that I'm ballsy enough to use the term because, look, we're the only field of medicine that rarely treats people against their will who are conscious, right? There's no other field of medicine that treats people against their will when they're conscious, other than psychiatry, or psychiatry is involved in helping to make those decisions. So we have some experience. So I want to just say one word about the ethics of coercion, because as you remember in our introduction, I'm a medical ethicist, right? So basically, that this kind of level of deployment of power is only justified, and I wrote a huge paper about this many years ago that became a seminal paper on this topic, is only justified if the purpose is the ultimate empowerment of the other person, right? So significant mental disorders basically diminish a person's autonomy and capacity for self-determination. So any kind of coercive or paternalistic maneuver that's done towards that person is only ethically justified if its purpose is to find a way to restore or at least maximize that person's autonomy, freedom, and self-determination. So not all behaviors then qualify, right? So the kinds of approaches that we're going to be talking about here are approaches whose purpose might in the short run appear to diminish a person's freedom. Like, look, I'm not going to pay for your car insurance right now. You can't have a car. You can't have internet access. You can't have your independent apartment until, that's a privilege, until you have taken the responsibility for this. So that's sort of the ethical argument to the person, but for yourself to know that you are engaged in manipulations. Let's use again a ballsy word here, Okay. It usually has negative connotations. I'd like to maintain all of these words have potential positive sides to them. That we're going to manipulate the environment in such a way as to move you towards the path that will ultimately maximize and restore your capacities, your autonomy, your self-determination. So that's kind of the ethical construct that I want to set up as we talk about these kinds of maneuvers.
Yeah, so I think that's great. And I think we have a kind of an interesting opportunity for a tangent, because I think out of everything that you've said, this has been the most engaging for our audience, and not necessarily in a positive way.
Oh, of course, I'm sure.
Right.
Whenever we psychiatrists talk about involuntary treatment, people go up the z-axis.
Yeah. So, and I think so now we've got kind of like a choice, right? And I'll put it to people who are watching. So I appreciate you for saying this. I think that like, I want to just offer like a couple of thoughts, responses, and then we have to figure out whether people, I'm curious whether people are interested in this discussion. I know that you're also like a renowned speaker for talking about physician assist or patient-driven suicide, physician-assisted suicide. You have thoughts on that and things like that. So there's a lot of stuff that I think that would be more up the z-axis and emotionally engaging, and arguably like less helpful.
Yeah, maybe we can have a whole other show about that topic.
Yeah, so I think we should, and I'm also kind of curious about if you've been following anything that's going on with ketamine usage, and people have been indicted with Matthew Perry. Like, there's a lot of stuff here that we could talk about. So I'm gonna just kind of ask chat, right? So like, let's just think about why we're here. We're here because there's a very real problem that people in your lives may need help. And right now we have a unique opportunity because we have someone who literally wrote a book about it and has shared already with us a lot of different things about, how to set the frame, how to have a conversation, what to say, what not to say, all for the goal of maximizing it. And I think that some of the stuff that Mark is saying right now sounds kind of scary, right? Because he's calling it manipulation. He's calling it coercion. But I think this is absolutely a step in the right direction. I don't think this is bad. I think this is the way that ethics really is.
Let's not sanitize it too much.
Right. So, and that's where a lot of bad stuff happens. When we coerce people and we don't call it coercion, that in and of itself is such a problem. When we manipulate people and we don't call it manipulation, that's
disingenuous.
Exactly. Yeah. So it's dishonest, right? So if we're going to do something that is exerting our will on another human being, let's at least call it what it is. So that's one thing. The second thing is that, I see a lot of like problems with this approach that you're taking, because there's an assumption that what will lead to a greater amount of freedom and autonomy over time, right? And there are all sorts of ways that, like, and I'm not disagreeing with you here. I'm in favor of certain cases of involuntary treatment, and I think that the main reason we need involuntary treatment is because we don't have the sufficient resources for voluntary treatment in the right way.
I don't know whether we're yet at the point where we're talking about involuntary treatment. We're talking about what's happening inside a family.
I'm with you.
Right. And yes, there is an assumption here. You've got to start with the assumption that contemporary, state-of-the-art, 21st century mental health treatment is helpful, is valuable, is at least able to improve things, manage things, sometimes even cure things. All right. So yes, because otherwise, don't bother picking up the book. I mean, if you are, an anti-psychiatry, anti-mental health, medical nihilist, right? Then I don't know, maybe you need to go to an ashram and, pursue that approach. Not that these are incompatible, but you understand what I'm saying.
Yeah.
So yes, there is an assumption here that moving towards state-of-the-art treatment is actually a good idea.
So I've had my fair share of patients come to me who are, in acute manic episodes asking, hey, do I really need medical treatment? Can I go to an ashram to fix this? And I will be the first to say, I think an ashram would really help you, but it certainly helps to not be acutely manic. And I don't think these two things are mutually exclusive. I think they're quite complementary.
And not only that, how many ashrams in the world will take an acutely manic person?
Yeah. Well said. So I'm kind of, I don't know if we have a clear, do you want to talk a little bit about coercion? We've got about 40 minutes left. Do you want to dive a little bit more into ethics?
Yeah.
Do you want to,
So yeah, all I want to just, and I've alluded to it already in this context, with working with a loved one, right? It is all about this idea of privileges versus responsibility and seeing the way in which privileges, because one of the important things is that the amount of the privileges of being a family member and the obligations of a family to each other are very different for minors than they are for adults, right? So, and particularly when we're dealing with parents of young adults, right? That the largesse of family membership is not an obligation on the part of the family to provide, right? Now, they're trying to provide, it's if somebody is ill, possibly they're providing largesse, again, with good intentions to try to keep the person out of trouble, right? Or maybe in their own idea, this is what's keeping them alive. If I didn't do this, they'd commit suicide, right? But in fact, I think that the starting point for this is to recognize that there are no obligations, true obligations, that family members have to one another. They're all optional, right? They're all optional,
powerful
except
statement.
for minors, right? For non-minors, they're all optional. So therefore, every largesse, every privilege, every benefit is up for negotiation, right? And can be used in negotiation to steer someone's behavior towards a certain outcome. In this case, the outcome is getting an evaluation. That's the only outcome, that we're interested in this context.
Yeah, so I mean, I've run into that a fair amount, and I think it's like that's something that I really want people to kind of take away, because I think we just have all these assumptions about what we provide. And a really common line of dialogue that I hear from especially the parents of children, adult children with gaming problems or things like that is, the child will, or this is an adult, right? So this is like a kid will be like, you're treating me like a kid. Like I'm a grown up. You can't take my video game away. And one of the things that is very useful is like, okay, we're treating you like you say you're an adult. Are you acting like an adult? Are these the things that an adult does? What is an adult capable of? Is an adult capable of doing their own laundry, sustaining themselves financially, things like that? And oftentimes I think parents are reluctant to say things that are hurtful for good reason. And I think this is oftentimes how we get here in the first place, right? Is a lot of enabling behavior, a lot of love, a lot of protection from consequences, which I see a ton from parents. Is that they're so terrified to protect their children from the consequences of their actions, because that's what your job is as a parent. Kids are going to want to walk to the edge of a cliff and peek over the side, and we as parents try to pull them back a little bit. That's what we do. It's our instinct. And so oftentimes people, and I think what can be quite helpful is to really think about the default position of what you think family is and what you automatically provide. And sure, you automatically provide that, but then what is the other person's responsibility to this relationship? Right? So it's my job to do this, this, and this, and it's your job to do this, this, and this.
And that responsibility doesn't begin at age 18, obviously, right? It's something that evolves and emerges more and more. But ultimately, the responsibility is fully instantiated by the time you reach adulthood. Now, whether you're capable of that responsibility or not, that's a different story, right? And you may not be. But I think that what is very important is for the people who are in the helper position. Okay, they need help. You need help as the helper, as we said in one of the meanings of the book, to overcome your own paradigm about why these kinds of approaches, why you're so uncomfortable doing these kinds of approaches, right? Why you either make a ethical argument to yourself. That's not nice to do. It's not fair to do. It's not moral to do. It's potentially hurtful to do. And by the way, there are risks involved, and sometimes what we have to talk about when people say, look, I don't want to force them to commit suicide, right? If I do that, they may take their lives, and that is, I mean, we have certain ways that we can, reckon suicidal risk, and we're not great at it, but we've at least got some ways of thinking about it. But the fact is that the risk of not doing something, not making a potentially therapeutic coercion intervention, may actually be just as serious and much more likely, much more probable to the risk of not doing anything than the risks that you're worried about.
Yeah, I think it's there's all kinds of ways that I think these unhealthy dynamics. You mentioned suicide, and I started, just thinking about how threats of suicide are one of the most powerful forms of coercion, manipulation, and enabling of bad behavior. It's probably like the number one thing, right? So it's so sad, but the moment that I see, a loved one, usually a spouse, romantic partner, child, or parent. So it has to be a very close relationship. And I've seen parents manipulate children with threats of suicide. I've seen, kids play this trump card, and boy, if it works, the relationship is so messed up because they're going to play it again, and they're going to play it again, and they're going to play it again. And then we see this a lot with romantic relationships too. I've had friends who have struggled because their partner, if you do X, Y, Z, I'm going to kill myself.
Yeah.
And sometimes that's a threat. Sometimes that's an expression of just profound suffering.
Yeah. And sometimes it's a self-justification. I mean, I've worked with a couple that they really needed to move into assisted living, and the husband really didn't want to go, but his excuse was, if I push for that, my wife would commit suicide.
Yeah.
Though she's never threatened suicide.
Do you have time, or do we have time to go over like a couple of samples?
Definitely.
Okay, so give me just so I'm going to read something out to you. Let me see if I can get this. Okay, so this is kind of okay, so we'll see if we can find the right. Okay. Oh, so this one is still. Hold on. Give me 1 second. I think we can get this to work. Nope.
You at least you're not having as many problems as Elon Musk.
Yeah, so we're gonna I'm gonna just go ahead and keep us on our original window, and I'm gonna just read this to you, okay? So,
Okay.
Help! My mom needs therapy. How do I get her to go? My mom is in the process of being diagnosed with a chronic illness. She isn't taking it well, and I think therapy could help her. I've dropped hints about therapy, but she's in a very negative headspace and keeps brushing it off. Has anyone had a success getting a parent into therapy? I'm caught between being afraid I'm doing too much and too little. I'm concerned about my mom because she's in a very negative and hopeless state of mind. Apparently, she's told my brother that her life is over and pointless. My brother is trying to organize a trip for her to cheer her up, and she refuses to even consider it. However, the reality is that she's made a lot of progress physically and is probably 80% back to normal. I talked her into getting a Fitbit, and she's logging 15,000 steps a day when 6 months ago she couldn't leave the couch by herself. It frustrates me that she's imposing these mental limits on her ability to enjoy all the things that she does have. She's also not taking the best care of herself that she can be, like getting an occupational therapist. Therapy has helped me so much. I feel like therapy with someone specializing in chronic illness could really benefit her. However, I also know that she's too negative right now to take the necessary and scary steps to go through with it.
Right. So that causes my brainstorming, to percolate, and thinking about many of the things we've already talked about. There are a couple of important things here. One is the good news is here that from this story, it sounds like this person has made a lot of progress below the neck, so to speak, right? But not above the neck, right? Which might be actually a way of framing the conversation, right? And that is, let's think holistically. Look at how much progress you've made below the neck with, whatever the contemporary things that medicine has to offer with that. So let's bring the above the neck into line with what you've accomplished below the neck. So, to build on the good news that she's a hard worker. You did the hard work to be able to rehabilitate to this point below the neck. So that shows me that, you can do hard work. So that's one thing that occurs to me. Another thing is that it sounds like the person who's writing here is in treatment themselves, in therapy themselves. So this is a great opportunity for that person to talk about their own treatment. What does it look like? What did I do? How did I get into it? What were my reluctances in the first place? How has it surprised me about what I've been able to get out of this that I never thought I could get out of this in the first place? So, that sort of the therapeutic optimism that comes from your own experience to, convey that to your mother might be, very, very helpful to her to say, look, what I want is I want to inspire you. I would frame this in terms of inspiration. I really want to inspire you. I don't want to coerce you. I don't want to force you, but I want to inspire you from my own experience. Right. So that's another thing that occurs to me in this circumstance. And then the question is, would there be an intermediate step for her? We talked about these intermediate sort of subclinical or preclinical
like a support
interventions.
group.
A support group. So if she has, cancer, right? We have, I could refer right away to wonderful things here in Baltimore that we have of support groups for people who have cancer or families of people who have cancer, and people talk about their emotional well-being and their feelings and whatever worldview has changed based on the disease that they have. There are also a great deal of online support groups now available for, whatever disease you've got. There's a Facebook group for that. There's an online group for that. So I don't know whether this mother, has the facility to do online support groups, but that could be a halfway journey towards and then maybe she'll hear other people in that group saying, I actually end up seeing a psychologist or a counselor, and it turned out it really, really helped me to turn a corner. Oh yeah, who did you see? Oh, Dr. Jones. Oh, yeah. Where is Dr. Jones? Right? Before you know it, possibly a effective referral has been made. So those are just a few of the ideas that come to me out of this case.
So I love those.
Oh, one more.
Yeah.
Sorry, one more. The treating physician. Right.
Oh, right.
So and that's a whole area we skipped over, which is allies. Yeah. Right. So primary care docs. So interestingly, as I'm sure you well know, Alok, that 9 out of 10 psychiatric prescriptions in this country are given by primary care physicians, not by psychiatrists. Antidepressants, anxiolytics, even antipsychotics, as a matter of fact, especially in contemporary time, because there are way more of them than there are of us.
Yeah.
Right. So talking to the primary care physician, can you go with your mother to her doctor's appointment? Can you bring that up? Also, can you leave a message for the primary care physician? I'm a little bit worried about my mother. The next time you see her, maybe you can talk to her about her depression, about getting some help. And maybe the primary care physician themselves would put them on something like Lexapro, right? Or to say, I got a colleague, I think it would really, really be a good idea if you talk to me. And sometimes people will accept a recommendation from their doctor that they would never accept from their kid.
So, I love your answer. I think it's like all of the right things. I have a cynical curveball for you coming up, but I just want to make sure that I've got this, so focus on, the fact that your loved one has made progress, right? So we can always take, if we think about the things that turn people off, it is, you need help, something's wrong with you, you need to fix this. There's a lot of this blame kind of language. We can dodge that by sort of saying, hey, you've done a great job. You're walking 15,000 steps. You used to not be able to get off the couch. Leaning into that leaning into, we don't have to jump straight to mental health treatment. There are things like support groups, intermediate steps, things like that, that can all be useful, that may be more amenable to people. Now, I don't know if this is just my personal clinical experience or being somewhat cynical, but, I've seen this a lot. So this is parent who has, with chronic illness, or someone with chronic illness, like a lot of these have been my patients, who they've made so much progress. And it's almost like the more progress they make below the neck, the less progress they want to make above the neck. That even though they're so resistant to the idea of getting better, like it's almost like there's some psychological need that's being met, right? Where like, and this maybe I'm just being cynical here, but like there are people that I've worked with where the more progress they make, like mentally, like the more they hold on to some amount of like this sick role kind of identity. And because sometimes like parents like, oh, you've made a bunch of progress. Like, I don't know how else to say this. Sometimes pointing that out to people seems to backfire. That's what I'm going towards. Where you point out to this person, you've made this progress. And especially with people with chronic illness, what I hear a lot is like, no, I haven't, but this is going on and, but this is going to come back. And
all right. So with that response with this particular kind of case, what I might suggest is to say, look, you wouldn't say this because it's too academic, but let's get away from Cartesian dualism, mind-body separation, right? So if you feel like you haven't made enough progress in your somatic problem, right? Let's be holistic about it. Let's understand that the mind and body are intimately connected, that the arrow that connects them has heads that go in both directions.
Okay, that's right? So good, dude. I love it. I love it. So like, because here's what I've run into, right? So on the one hand, okay, we've made a lot of progress. Good job. And sometimes when I work with people, when I say good job for the progress that you've made, they're so resistant to that. They're like, no. And so I love it.
One of the reasons they're resistant is they may be afraid that you'll no longer want to treat them.
All kinds of challenges, right? So that's, we dig into all that stuff. But I like that it's such a good twist, right? So, okay, if you haven't made enough progress, let's meet you where you're at, right? And say like, okay, wow, like we haven't really, you've been working so hard and things are still so hard. Right. Let's get more help. I love it. Right. Love it.
Get more help and let's bring to bear other things that haven't been tried. And let's not pretend that the mind is irrelevant to the body.
Yeah.
Or the body to the mind.
And I think people do have some really solid takeaways here. And I think the number one takeaway here is, I love this. There's a comment from chat that I have to share with you. I'm now imagining the kid responding, Mom, let's get away from Cartesian dualism. So I think that's what people are going to,
Yeah, well, that sounds like me talking to my mother.
Yeah. So here's another one for you. So I asked my boyfriend to go to therapy, and he hasn't gone despite agreeing to. My boyfriend, 23 male, and I, 22 female, broke up about a year ago and were apart for 2 months. We got back together on the terms that he would go to therapy so he could be more emotionally available by not only understanding his emotions better, but also understanding mine. He not only said he would go, but seemed enthusiastic about it at the time. It has now been about 9 months and he still hasn't gone. Every time I've brought it up, it has been a touchy subject. I've tried to help him understand that it isn't because something is fundamentally wrong with him, but because emotional intelligence is a skill. He finally agreed again about a month ago, but has done nothing to find a therapist. We moved in together in May, and the last few months have been really rocky and emotionally draining. We've been fighting a lot and just aren't seeming to click. I have felt more drained than lifted up by a relationship during this time and am seriously considering leaving, but I'm really not sure that I'm ready to be done because I love him a lot and he is my best friend. Sometimes, though, I feel so resentful that changes weren't made earlier, and I'm not sure that I can put more energy into the relationship until I know he's serious about going. Please help. I'm so torn and don't know what to do here. I would really appreciate some advice because I don't want to waste my time, but I also don't want to just throw in the towel.
Well, obviously, we're not going to solve this complicated problem standing on one foot, but just remind me, is the goal couples therapy or his individual therapy?
I think it's individual therapy.
Individual therapy. Okay. So first of all, this person sounds like they could really use a therapist of their own if they don't already have it, right? I mean, they're clearly struggling with their frustrations, with the dynamics of the relationship. Being in a relationship in which there was a cardinal promise that was the starting point for reinitiating the relationship was that he was going to get help, and yet she's still in it, right? So clearly she has some stuff to work out on her own, and hopefully, she has that resource. I think that this is absolutely something that is a excellent opportunity for repetition, right? I mean, this is something you don't let go, right? This is something that you keep going back to first principles and say, this was the agreement. This was, our covenant, our pact is that you would do this. Now, I understand it's hard to do. I understand you're reluctant to do it. What do I need to do? What can I do, that would help you fulfill your promise? This was a promise. This was a commitment. I keep going back to promise keeping. Okay. This is a promise. What can I do to help? Would you like me to find a therapist for you? Would you like me to call and make the appointment for you? Be glad to go with you to your first appointment. I'll set the appointment. If I set the appointment, would you go? So in other words, I wouldn't, rather than being so passive about it, which is, well, you promise, come on, you promise. How can I be proactively helpful? Now he may say, forget it, I'll do it myself. So I think that's that's a possible approach. But I think that if indeed you feel that this was and continues to be the sine qua non, that without which this relationship isn't going to work, if it has a chance, I mean, it might not even work if he goes into therapy, but if it has a chance, if you're convinced the path to this relationship becoming stabilized and satisfactory is through his getting some help, then you need to see that as an existential issue for the therapy, right? So that you would have to make it clear. And this is sort of the ultimate coercion that we didn't, well, the two ultimate coercions are putting someone out of your house or ending a relationship. And that's sort of at the very end of a sequence as a last resort, and probably requires some professional counseling for you if you're going to do that. And, that's definitely not, not best to totally do it on your own thing. So to be able to say, look, here's the deal. Here's the deadline. Okay. If you want to continue this relationship, which we agreed was important for you to get this kind of help, I'll do everything I can to help you find people and so forth. But if that's not done by such and such a date, I think we need to call it quits. We need to hang it up. So that's a strategy. Now, is it a bluff? Is it not a bluff? I mean, that's up to her. And by the way, sometimes strategies have to be a bluff because they have to be, but hopefully not
Another
often.
ballsy statement.
Right.
I
But
think
sometimes
it's,
they have to be a bluff.
yeah.
Right. I don't know. I know I'm really ready to leave him, but I'm going to say it, and then we'll see how I feel when we get to that date. Right. So those are, a more of a both a facilitative approach with, let me help you find somebody, find the right kind of help for you, and make the appointment, go with you to the appointment. And it's also a hardball approach, which is,
Yeah.
this is your promise. You need to keep your promise. You need to keep your promise by such and such a date, or this is done.
I'm really appreciating like how much of a toolbox you're giving us, Mark, because like I can hear, so there's the answer that you just gave us, but I could construct a different answer from what you said earlier, which is, okay, so on the one hand, it's like, let's be proactive, let's be supportive, let's, move towards a goal. And also that could cross over into enabling. And if you make the appointment, there's a chance that he won't go, right? So there's that angle too. I think there's also like you were kind of saying about, there's something to be said for someone who's like, I don't want to give up on this person and this is emotionally draining for me, so that this person may need their own help. Why is it hard for you to enforce consequences in a relationship? This was a condition. The condition already has not been met. Right?
Exactly.
So now we're sort of saying, okay, like, but I'm serious this time. This time I'm going to enforce the condition. And that could be a bluff. I think you beautifully read into that. And you were kind of like, this person may not be able to stick with it because they haven't been able to stick with instituting consequences already.
By the way, let me just say, you said maybe she can make the appointment for him and then he not show up.
Yeah.
Which would be unfortunate, but wouldn't that be clarifying to her?
Absolutely.
If when she makes the appointment, even when there was a date and a time and he said he would go and he didn't show up, that could be very useful, valuable
information,
data.
Absolutely. Right. So now you have removed every obstacle, and the only thing in the way is willingness or a lack thereof. And that gives you your answer. So totally see that too. Right. When you make all someone has to do is show up, and you move from all the obstacles, all the logistical obstacles in the way, that's when you'll really get your answer on how committed this person is, because then they don't have another excuse.
Right, which is why, by the way, when people are thinking about leaving their relationship, I strongly recommend that rather than sending the relationship to hospice, they take the relationship in as a patient for treatment. And if even then that's not successful, you can leave the relationship more easily knowing you turned over that very last stone, and even that didn't help.
That's huge. I think that's something I've seen a lot as a psychiatrist, that, if you're stuck in a relationship because you're like, oh, I love this person, but I can't deal with this anymore, we're so conflicted, I think doing everything that you can do makes it so much easier to leave. And oftentimes the advice that I kind of see on the internet, and take that for, what it's worth, is like, if someone's not doing their part, you shouldn't do your part. And it's so interesting, because that can be the right answer, right? But it can also be the right answer of like, okay, I'm going to do everything that I can. Therefore, I can sleep at night and I can say, okay, like, right, I did everything I could. This relationship is still not working. They're not carrying their weight, and it gives you peace of mind to leave.
And by the way, if he does go to therapy and he doesn't change in ways that she finds fulfilling and acceptable, that too will make it easier for her to leave. Like, even with therapy.
Yeah. So, it's interesting. I've had this experience before, because you were saying that will make it easier for her to leave. I've seen the flip side of it. Whereas if he goes to therapy and she's still not satisfied, he leaves. And I've had patients who have, been forced into therapy by a spouse, and then realize, oh, like, my partner is blaming me for all of this stuff that is actually their fault. And then the person who is forced into therapy dumps their spouse or romantic significant other, dumps their asses, and then moves on with their life. And so I've seen that too.
At least somebody's growing.
Someone's growing. I've seen it even from like I had a patient who came in because someone at their job was like, hey, like, you should see a therapist because, you're really struggling. And then they realized, like, I don't fucking want to work here. because it's stressful. And that's the
Right.
reason I'm suffering. And then they quit.
Right.
Right.
So yeah, you be careful what you ask for.
Yeah.
Right.
And so it's really interesting.
And they may leave because you may be part of the problem.
Absolutely.
Right. Which is where we started in talking about, sometimes the helper is going to need help, not just for support, but maybe to change some of the way in which they might be inadvertently making the situation worse. Right. Now, I want to talk about one more particular instance that we didn't cover that I think is important because I just recently heard that, which is the person who doesn't have the primary condition, but is in denial about the person's primary condition, right? So minimizes it, is in denial about it, doesn't think the person needs treatment when they really did. So two examples come to mind. One is the Sandy Hook shooter, Adam Lanza, whose mother, who saw how much the kid was suffering, did not ever consider that he needed any sort of help. And the other was the Crumley case, with the parents who got convicted of giving the kid a gun in Michigan, the first parents to ever be convicted for, involuntary manslaughter because they missed all the signs. So the in the testimony, the 15-year-old shooter he was tortured. He was severely mentally ill. And he went to his father and said, I need help. I need to see somebody. And his father, he said on the stand, my father gave me a pill and told me to suck it up. And then I went to my mother and I told my mother what my father said, and she laughed.
Wow.
So I also want to think about the special circumstance in which, here we're talking about people who pick up this book because they know their loved one needs help. But I think we need to mention sometimes people who see that there's a significant mental disorder going on, who minimize it or believe, mental health treatment is a bunch of crap anyway. Maybe they just need to go to church more, right? Or join the softball team, or, have more time on the shooting range, and ignore, overlook, and deny the problem. So I just want to include that category in our discussion.
I appreciate that. I think the one thing, it's so interesting because when I hear you talk about that, I find myself like opening up all kinds of questions that make me really think. I would love to have a second discussion with you about ethics, about some of these cases that we hear about.
I'll have as many discussions with you as you want.
Yeah. So I think I know we're almost at time today. So everyone, this is Dr. Mark Komrad. Dr. Mark Komrad is a psychiatrist who's been practicing for 30 years. And it's interesting. He kind of stumbled into having his own radio talk show where people would call in and ask for help. And it was Komrad on Call, right? And it has had 43 million listeners. So was kind of, has done something in the public space as well. And the most common question that he got is, how do I get a loved one into therapy or into help? And Dr. Komrad has written a book about it. It's actually a question we get incredibly commonly. So I see like posts on our subreddit and people are asking in Discord and stuff like that, how do we get people into, how do I help someone get into help? Because there are so many barriers to it. There's so much stigma. Where can people find your book, Dr. Komrad?
Well, I think the easiest thing is the book has its own website.
Okay.
And it's in Barnes and Noble, it's on Amazon, it's everywhere. But if you want to delve into what the book more and some sample chapters and things like that, its website is youneedhelpbook.com.
Okay, awesome.
Youneedhelpbook.com.
So if you have a loved one who, you really think they would benefit from therapy, there are posts about this all over the internet, definitely check out Dr. Komrad's book. And I think we'll have potentially a more, how can I say this, maybe contentious or spicy discussion about ethics and physician-assisted suicide and some of these other things. You're, a medical ethicist as well. So I think there's a lot more to talk about. And you seem also very familiar with some of these like media cases and things like that.
Yes.
So I'm curious if you have a background in like forensic psychiatry, or this is just if it's just tangential.
I'm actually not a trained, by fellowship forensic psychiatrist, although I've done some forensic work and some expert witnessing and stuff like that. But, because there's obviously great overlap between law and ethics, although they're not identical.
Yeah. So thank you so much for coming, Dr. Komrad. And if y'all are interested in the book, youneedhelpbook.com.
Right.
All right. Take care.
Thank you so much. I look forward to talking with you again.
Adios.
Bye.
All right. So that was fun. And I saw some of the comments in chat. Like, so I know, like, this is the challenge, right? So, like, sometimes the stuff that is useful at accomplishing your goals is not always the most memeish. And like, I like Dr. Komrad because he'll tell it like it is, and I saw the reactions in chat when he was like, yeah, like this is coercion. And it's like, yeah, it is. But I think what's good about it is like, we call it what it is. Like, that's what we do. We give it these euphemisms like, oh, this is tough love, right? This is the imposition of consequences. That's sometimes what coercion is holding people accountable. But let's call it what it is. I've had this experience even with like patients and family members and things like that. When I'm doing something to them that they don't like, the worst thing that I can do is call it something positive for the sake of my own ego. If I'm being coercive or controlling towards someone in my life, like, I should at least call it that, right? And I, even as a psychiatrist, like, one of the most damaging things that I've ever seen parents do to kids is do something bad to your kid and call it something good. I'm doing this because I love you. This is an expression of love. That's why you're going to stay in the fucking basement for 1 week and I'm going to send you down food and water. I do it because I love you. I've seen all kinds of terrible things done for the sake of some kind of mental gymnastics, and then we don't call it what it is. That's what really screws up the kid. Like, the harsh punishment is one thing, but then telling someone, hey, this is love. And so then this poor kid grows up, and then someone treats them with love, and then they get fucking confused because the person who's loving them is not sticking them in a basement. Right? I've heard these stories, like, it's awful, like trigger warning incoming. But, people will like physically hit their kids and they'll be like, I do this because I love you. Right? And it's like, and that's what the parent, that they're not talking to the kid, they're talking to themselves. This is the thing when your mind tells you, hey, what you're doing is wrong, but you feel like doing it because you're angry, what your mind will do is mental gymnastics and say, you got to do this. I feel like fucking doing it, but I'm doing it because I love you, not because I'm angry and I'm frustrated and I'm stressed and I can't get you to comply with my wishes. And then we dress it up as something called love. And it's ballsy. And it's like, if we're going to do something bad, let's call it what it is. Right? Like, and I one time had a teacher, an attending psychiatrist, who's teaching us about borderline personality disorder. And so she treats almost exclusively, I think, borderline personality disorder. I don't know exactly what the composition of her practice is. But, one day she was kind of telling us like this story about a patient of hers. And so the patient of hers is like doing better now. So the treatment is kind of like ending, right? And so she's like, hey, like, I'd love to talk to you. Can we stay in touch? And the psychiatrist is like, no, I don't see the point of that. This is a clinical relationship. My job here is to help you with your mental illness, which now you're doing better. I've really enjoyed working with you, but I don't think it's appropriate to stay in touch. And like, to say that with someone, if you guys are familiar with BPD, to say that with someone with BPD is like kind of like a slap in the face. And this person knows more than I do. So I think it's like kind of the right thing to do. I mean, I wouldn't say that personally, And at the same time, it's kind of like the problem with BPD is that people have abandonment issues and they'll be clingy, and then like it opens up. And the reason that she says this is not because she's an asshole. It's because she recognizes that people have like these abandonment issues and they read too much into relationships. And if this person says, hey, can we keep in touch? And then they send you a 3-page email and you don't respond within 24 hours, how is the person going to feel? If you respond within 24 hours, but it's 1 paragraph instead of 1 page, how is the person going to feel? If they send you a 1-page email and you respond with a 1-page email, and then the next week they send you a 1-page email and you don't respond with a 1-page email, how is this person going to feel? Right? That's the challenge with BPD. Seems like a real asshole move, but like once you're in, there's a reason that this is the safest way, because what does that mean? Can we stay in touch? What is the responsibility that you're signing up for? Right? So it's like, it's kind of wild, but I think props to Dr. Komrad for calling it what it is. He's like, there's 2 pathways here. There's the supportive pathway and there's the coercive pathway. And sometimes when it comes to mental health, like people are coercive. Like that's the reality of it. Now, whether that's the right thing to do or the wrong thing to do, I think that's a topic for a very good discussion. I don't have an objectively correct answer. I have simply my experience and my opinion. And I think it's like an important point of discussion. Right. But I mean, I've seen it where like people, parents will try to be coercive, and sometimes parents are too coercive and sometimes they're not coercive enough. I've seen both. I've seen parents who are incredibly controlling and incredibly coercive. Oh, yeah, we're doing it because it'll make you happy one day. No more video games. You're going to play the violin, you're going to be a tennis player, and you're going to go to med school and become an astronaut. We're doing it because it'll make you happy. We're doing it for your happiness. You're miserable when you're a kid. You're miserable when you're a teenager. You're miserable when you're in pre-med. You're miserable when you're in med school. We're doing it for your happiness. You just don't know how to. This is crazy. You're so ungrateful. You've been given everything except for freedom. Right? So, I mean, like, it's all kinds, and I don't have a right answer, and I think it's like, I don't know who does have a right answer. I think if there was a right answer, there would be a lot less discussion. I think what we have is the best answer that we have today, and hopefully that answer evolves over time. So I really props to Dr. Komrad for, like, calling it what it is. And I think the other cool thing is, like, let's be honest, like, we're in these situations with loved ones where there's a carrot and there's a stick. There are privileges and there are responsibilities and there are consequences. What exactly is coercion? Coercion is usually the implementation of consequences to induce a certain kind of behavior. And that's why, like, he takes an ethical approach to it. And he's like, okay, like, what is the right circumstance in which we do this? Like, the goal is, like, forcing you out of your bed and hopefully, like, coercing you into treatment is so the goal that if if you're in a good frame of mind, then you can live your life however you want to. So I think it's all like really important stuff to talk about. I think it's super challenging. And like, I'm actually kind of hyped that there's a book out there that actually talks about it explicitly. Which is like, let's be honest. I mean, there's a book about, the carrot and the stick. Like, that sounds like a good book. You know what I'm saying? All right. So thank y'all so much for coming today. I really hope this is helpful to y'all. We're going to be back on Monday where I'm going to be doing a deep dive into autism spectrum disorder. We've got 2 memberships lectures coming up next week. One is on Emotions 201. Good news is if y'all sign up for memberships today, you guys can watch 101. Also, if y'all are going to show up to the 201 lecture, please watch the 101 lecture. This is another thing that we're doing over on the membership side is we are expecting that people have watched some stuff from the past. So the challenge that we run into when we stream something is we always have to start from the beginning. And so what that means is that unless we're doing an 8-hour marathon stream, like we can't do it's very hard to do a part 2. And y'all may say, well, but why don't you just do a part 2? Well, it's because like the expectation on stream, if we do a part 2, we've tried it before. And what we find is each subsequent part that we do, more and more people like don't understand what we're talking about, which is fair enough, right? So check out Emotions 201. We're going to be talking about a couple of like nuances of emotion. So we covered the basics of emotions already. Things like, emotions are a source of information and motivation. Why do we have each emotion? What is the purpose of each emotion? Kind of how do you manage each emotion? And next time what we're going to talk about is sort of like it's a higher level of understanding emotion. So we have two categories of emotions. We have our primitive emotions and we have social emotions. So we have primitive emotions like anxiety, anger, stuff like that. Those all come from our amygdala, and we as human beings actually have this other emotional circuit from our brain, which gives us pride, shame, and guilt. So the emotions that relate to other human beings come from a different place, and the way to manage those emotions is different from the more primitive emotions. And then the last thing that we're going to talk about, this is kind of wild, but it's very vogue nowadays to say that, all emotions are good. And I'm someone who says that, right? So anger has an evolutionary purpose. But if we sort of think about it, there's not like, while all emotions are good, we also like have to acknowledge that if you experience some emotions, your life will be better than if you experience other emotions more consistently. So if I'm angry for 365 days a week, if I'm anxious for 365 days a week, my life will be less good than if I am joyous 365 days a week, if I am happy 365 days a week, right? And so we're also going to dive into the cultivation of positive emotions, which interestingly enough, from the neuroscience psychiatry perspective, we're not great on, actually. Anyway, so that's just an example of what we kind of cover over there. And we have our deep dive into intuition. So understanding intuition from different perspectives. So if y'all are interested, check that out. And then we have, the deep dive into autism on Monday. That's not a membership stream. That's going to be streamed to Twitch and YouTube simultaneously and is for everyone. And my hope is that that'll be like the first of something. So it's a stream that is honestly probably going to run long because I don't think I can finish in 2 hours. There's a lot to say. And so hopefully we'll have time for Q&A and things like that. So sorry for not being able to do it on time, and it's coming up, okay? Meditation guide when? We have a meditation guide. So we have guides for meditation, ADHD, trauma, depression, and anxiety. These are like things that I've spent months, and each one of the guides is basically the length, like the script for the guides is like the length of a nonfiction book. So instead of writing books, I made guides. So check that out. Okay. So when was the meditation guide? It's available. It's one of Dr. K's guides to mental health. Yeah, I mean, people like all of them. So I think you can get them all too. So whichever one, I'm glad that, someone loved the ADHD one. That's why we make them. So we try to kind of do everything for everybody at all levels of engagement. So if you're like, okay, I want like 12 hours of stuff on meditation, then check out the guide. I want to do some meditation stuff every week and I want it to build in a sequence, then check out memberships. I want an introduction to something, or I want stuff for free, check out resource packs, which are a little bit more longitudinal and are absolutely free. And then we've got our like regular streams, and we've got like 1,000 plus videos on our YouTube channel. Twitch, of course, doesn't keep streams for very long, so that's unfortunate, but check out whatever Twitch VODs we have available as well. So happy Friday, everyone. I hope y'all had a good weekend. And I, unfortunately, even though I installed Deadlock, I don't know if I really feel like playing Deadlock, man. It's just like learning a whole new game. Come on, chat. All right. Take care, everybody. We'll see y'all on Monday.